Between 11 p.m. and 4 a.m., a cluster of dopamine neurons deep in your brain, called the A11 group, reduces its output to your spinal cord by as much as 30%. That single drop is what makes your legs crawl, ache, and refuse to stay still. A 2019 global analysis published in Sleep Medicine Reviews estimated that 7 to 10% of adults suffer from restless leg syndrome, but among those over 65, the number approaches 19%. Most are never told why it happens at night, and the answer is a nerve signal that vanishes on a schedule. The common assumption is that restless legs happen because you are tired, that after a long day your legs simply ache, and you notice it more when you are lying still. Your doctor may have said it is just one of those things. Some people assume it is poor circulation. Others blame it on too much sitting or not enough exercise. None of those explanations account for the defining feature of restless leg syndrome. It has a clock. It arrives at the same time every night, peaks between 11 p.m. and 2 a.m., and nearly disappears by morning. If this were fatigue, it would not vanish at 6 a.m. when your body has slept the least. If this were circulation, standing up would not relieve it instantly. If this were from sitting all day, it would be worst in the afternoon, not the middle of the night. Restless leg syndrome is a neurological condition with a circadian rhythm. It follows the same 24-hour pattern every single day, and that pattern matches, almost perfectly, the nightly decline in dopamine activity in one specific neural pathway. A study by Mayo and colleagues, using a 28-hour constant routine protocol, where subjects stayed in the same reclined position, awake, for over a full day, confirmed that RLS sensory symptoms and involuntary leg movements follow a clear circadian oscillation. Worst at the circadian temperature nadir, independent of posture, independent of sleep deprivation. But the real question is, which dopamine pathway is failing, and why your brain cannot compensate at night? The answer involves a group of nerve cells that most neurologists never discuss by name. Your brain has multiple dopamine systems. Most people know about the one involved in reward, the mesolimbic pathway. Some know about the one involved in movement, the nigrostriatal pathway that degrades in Parkinson's disease. But there is a third pathway almost nobody talks about. It is called the diencephalospinal dopamine system, and it originates from a tiny cluster of cells designated A11. The A11 cell group sits in the posterior hypothalamus, near the border of the thalamus. It is small, it is obscure, but it has one critical function. It sends the longest dopaminergic axons in your entire nervous system, projecting all the way down your spinal cord, into the dorsal horn, and onto the networks that process sensory signals from your legs. Think of the A11 system as a volume dial for sensation. When it is active, it releases dopamine onto spinal cord neurons, suppressing low-level sensory noise, tingling, crawling, aching, the background static of your peripheral nerves. During the day, this system keeps the volume turned down. You do not feel your legs unless something meaningful happens. A cramp, a bruise, an actual stimulus. But at night, the A11 system reduces its output. This is normal circadian behavior. Dopamine production in this pathway follows a 24-hour rhythm, declining as melatonin rises and core body temperature falls. In a healthy system, this decline is modest. The volume dial turns down slightly, but your sensory gate still holds. In RLS, that gate fails. Dr. William Ondo at the University of Texas Health Science Center performed a landmark experiment in 2000. He injected the neurotoxin 6-hydroxydopamine directly into the A11 nucleus of rats, destroying those specific dopamine neurons. The result? The rats showed significantly increased standing episodes and motor restlessness, particularly during their rest phase. The behavioral pattern matched RLS. When you destroy A11, you remove the brake on spinal sensory processing. Every minor nerve signal from your legs, signals that your brain would normally suppress, gets amplified and delivered to consciousness. At 11 p.m., when your A11 neurons naturally reduce their firing, you feel it. That crawling sensation, that impossible to describe urge to move. It is not pain exactly, it is not numbness. It is the sound of your spinal cord screaming without a mute button. Garcia Borreguero and colleagues at the Sleep Research Institute in Madrid confirmed in 2004 that cerebrospinal fluid dopamine metabolites show a significant circadian variation in RLS patients, with lower values at night compared to morning, a pattern not seen as dramatically in controls. But here is the part nobody mentions. The A11 system does not fail randomly. It fails because it is starving. Iron. That is the missing piece. Not the iron in your blood, the iron in your brain. Dopamine production requires an enzyme called tyrosine hydroxylase. This enzyme converts the amino acid L-tyrosine into L-dopa, the direct precursor to dopamine. And tyrosine hydroxylase cannot function without iron as a cofactor. No iron, no enzyme activity. No enzyme activity, no dopamine. It is that direct. Multiple autopsy studies, including work by Dr. James Conner at Penn State College of Medicine, have shown that the brains of RLS patients contain significantly less iron in the substantia nigra and putamen compared to controls. MRI studies by Schmidauer and colleagues confirmed decreased iron content in subcortical regions. And critically, cerebrospinal fluid studies show lower ferritin and lower iron in RLS patients, even when their blood levels appear normal. This is the paradox that confuses most doctors. Your blood test says your iron is fine, but your brain is iron deficient. The blood-brain barrier controls iron transport independently from the rest of your body. Dysfunction in endothelial iron regulatory proteins at the blood-brain barrier can starve the brain of iron while the rest of your body has adequate stores. If you have ever lain in bed at midnight, legs twitching, and your doctor told you that your labs are normal, this is likely what is happening. Your labs measured blood iron. Nobody measured brain iron. And brain iron is what your A11 neurons need to manufacture dopamine. Now layer the circadian problem on top of the iron problem. Research by Garcia Borreguero demonstrated that serum iron itself follows a circadian rhythm, dropping at night, rising in the morning. This parallels the timing of RLS symptoms almost exactly. At night, both dopamine production and iron availability decline simultaneously. For someone whose brain iron stores are already marginal, this nighttime drop pushes the system below threshold. The A11 neurons cannot produce enough dopamine. The spinal cord sensory gate opens, and your legs begin to move. If this is making sense, and you want the section about exactly what to do about it, the specific protocol that addresses both the iron pathway and the circadian pathway, subscribe now. That section is coming in about 4 minutes, and it changes the way you think about this condition permanently. But none of this explains the most disturbing part. What happens inside your peripheral nerves themselves, and why your legs feel worse than any other part of your body. What almost nobody talks about is the peripheral nerve component of restless leg syndrome. For decades, RLS was considered a purely central nervous system disorder, a brain problem. But a growing body of evidence suggests that the legs themselves are sending abnormal signals. A study by Polydefkis and colleagues at Johns Hopkins examined 22 consecutive RLS patients with skin biopsies of their leg nerves. Of those 22 patients, 8, more than a third, showed objective evidence of peripheral neuropathy, including 5 with small fiber neuropathy that would never appear on a standard nerve conduction test. Their standard EMGs were normal, their neurological exams were normal, but under a microscope, the small sensory nerve fibers in their legs were damaged or reduced in number. These small C fibers carry deep, poorly localized sensations, exactly the kind patients describe. Not sharp pain, not numbness, something between, something crawling, something that demands movement. A study by Bachman and colleagues used the current perception threshold test on 30 RLS patients and 22 controls, testing sensory nerve responsiveness at different times of day. At 5 Hz, the frequency that selectively stimulates pain-related C fibers, RLS patients showed significantly lower detection thresholds in the evening compared to controls. During the day, the two groups were identical. At night, the RLS nervous system became hyperexcitable, and the hyperexcitability was most pronounced in the exact fibers that carry the sensations RLS patients report. Read that again. Your peripheral nerves are not just passively waiting for a brain signal, they are actively amplifying at night. The sensitivity of the fibers themselves follows a circadian rhythm. So here is the complete picture. At 11 p.m., 3 systems collapse simultaneously. Your A11 dopamine neurons reduce their spinal output. Your brain iron availability drops to its circadian low, and your peripheral C fibers become hyperexcitable. The suppression system weakens from above, the signal source amplifies from below, and your conscious brain, lying still in the dark, receives a barrage of uncomfortable, urgent, impossible to ignore sensations from your legs. The research is still evolving on whether the peripheral nerve changes cause the central changes or vice versa. Some scientists dispute whether small fiber neuropathy is a co-occurring condition or actually part of the RLS mechanism itself, but the clinical overlap is undeniable. So the question becomes, if your dopamine is circadian, your iron is circadian, and your nerve sensitivity is circadian, how do you intervene at every level? Step 1. Get your ferritin tested and demand the right threshold. Most labs report ferritin as normal if it is above 12 or 15 nanograms per milliliter. But the Mayo Clinic's 2021 updated RLS algorithm, authored by Dr. Michael Silber and colleagues, recommends treating RLS with oral iron when ferritin is 75 micrograms per liter or below. Not 15, 75. Ask your doctor specifically for this number. If your ferritin is below 75, take 65 milligrams of elemental iron, typically as ferrous sulfate 325 milligrams, every other day, with 100 to 200 milligrams of vitamin C to enhance absorption. Take it on an empty stomach, in the morning, not at night. Morning dosing aligns with your body's peak iron absorption window. Step 2. Time your physical activity correctly. Moderate exercise, 30 to 40 minutes of walking or cycling, performed in the late afternoon between 4 and 6 p.m., has been shown in multiple studies to reduce RLS symptom severity that same evening. But exercise after 8 p.m. can worsen symptoms. The timing matters because afternoon exercise raises your core body temperature at the right point in the circadian curve, promoting a steeper decline later, which is associated with deeper sleep and reduced RLS activity. Step 3. Avoid dopamine-blocking substances in the evening. Alcohol suppresses dopamine receptor sensitivity. Antihistamines, including diphenhydramine, the active ingredient in most over-the-counter sleep aids, can worsen RLS significantly. Caffeine after 2 p.m. has been linked to increased PLMS index in polysomnography studies. If your legs are restless, your evening chemistry must protect dopamine, not suppress it. Step 4. Consider counterstimulation at symptom onset. When the crawling begins, apply firm bilateral pressure to both calves using your hands, a foam roller, or compression sleeves for 60 to 90 seconds. This activates large diameter A-beta sensory fibers, which, through the gate control theory of pain, can temporarily inhibit the smaller C-fiber signals driving the restless sensation. It does not fix the underlying problem, but it buys you a window to fall asleep. Step 5. Discuss alpha-2 delta ligands with your physician if symptoms are moderate to severe. Gabapentin enacarbil, approved by the FDA for RLS in 2011, works not on dopamine but on calcium channels in spinal sensory neurons, reducing the hyperexcitability at the nerve level. The International RLS Study Group's 2016 treatment guidelines list it as a first-line option, particularly for patients with painful RLS or concurrent small fiber neuropathy. This is not a dopamine drug. It targets the peripheral amplification problem directly. If even one of these steps was new to you, hit like. It tells the algorithm to show this to more people whose legs will not let them rest, and who deserve to know why. Here is what I want you to understand about restless legs at 2 a.m. It is not in your head. It is not anxiety. It is not because you did not walk enough today. It is a measurable failure of a specific dopamine pathway, the A11 diencephalospinal system, combined with a circadian drop in brain iron availability and a nocturnal amplification of peripheral nerve sensitivity. 3 systems, 1 time window, 1 unbearable sensation. This condition was first described by Thomas Willis in 1685. That is over 340 years ago, and the majority of people living with it today have never been told the mechanism. They have been told to stretch, told to relax, told their labs are normal, told it is age. It is not age. It is a signal your nervous system can no longer suppress. I want to hear from you. Drop a comment below. At what time of night do your symptoms peak? And has any doctor ever checked your ferritin level specifically for RLS? I suspect most of you will say no. That needs to change. Your legs are not restless because they are broken. They are restless because they are unguarded. Share this with someone whose legs keep them awake every night. They have probably been told nothing is wrong. Something is wrong, and now you know exactly what it is. If you have not subscribed yet, do it now. What I am building for next week connects this dopamine pathway to something far larger, a system that governs not just your legs, but your mood, your motivation, and your ability to feel rested. It is the same circuit, and almost nobody is talking about it. Stillness is not silence, it is permission.